Dr. Nardi here, back with another video. In this video, we will delve into the complex world of mood disorders, specifically covering their clinical presentation, prevalence, co-occurring conditions, causes, and various treatment options. This video focuses on two main topics from the DSM-5 TR, depressive disorders, and bipolar and related disorders. When studying mood disorders, they fall into two distinct groups, depressive disorders and bipolar disorders. The crucial difference between these two groups is the presence of episodes of mania or hypomania. Individuals with depressive disorders have never experienced a manic or hypomanic episode. The two most common types of depressive disorders are major depressive disorder, or MDD, and persistent depressive disorder, or PDD. Major depressive disorder requires discrete episodes lasting at least 2 weeks, where there are substantial changes in affect, cognition, and neurovegetative functions. To meet the criteria, an individual must experience at least 5 symptoms, and one of those symptoms must be either a depressed mood or loss of interest or pleasure. Persistent depressive disorder is a continuous and chronic form of depression. An individual must experience a depressed mood for most of the day, for more days than not, for at least 2 years. While symptoms are similar to major depressive disorder, they are generally less acute and tend to ebb and flow over this long period. It's important to note that symptoms of depression generally fall into 4 categories. Mood symptoms include a depressed mood for most of the day and feelings of anhedonia, which refers to a loss of interest in previously enjoyable activities. Behavioral symptoms often involve decreased physical activity and reduced productivity at home and work, leading to a disruption in daily functioning. Cognitive symptoms are characterized by negative views of oneself and the world, feelings of worthlessness, self-blame, difficulty concentrating, and sometimes thoughts of suicide and self-harm. Physical symptoms often involve changes in sleep, such as excessive sleeping or insomnia, as well as fatigue, changes in weight or eating behaviors, and slowed or purposeless physical movement. Bipolar disorders are characterized by shifts in mood, activity, and energy. Bipolar I disorder requires the experience of at least one manic episode. This manic episode may be preceded or followed by a hypomanic or major depressive episode, but the manic episode is the only criterion required for diagnosis. Bipolar II disorder requires a current or history of a hypomanic episode and a current or past major depressive episode. Crucially, an individual with bipolar II must not have a history of a full manic episode. There are several differences between manic and hypomanic episodes. A manic episode must last for at least 1 week, while a hypomanic episode must be present for at least 4 days. The severity of a manic episode is significant enough to cause impairment in social or occupational functioning or require hospitalization. In contrast, hypomanic episodes are not severe enough to cause impairment or hospitalization. The symptoms also differ in intensity. Manic episodes involve an abnormally persistent or expansive irritable mood with increased activity and energy, often accompanied by grandiosity, decreased need for sleep, being more talkative, racing thoughts, and distractibility. Hypomanic episodes also involve abnormally elevated, expansive, or irritable mood and energy levels, but the behaviors are not as extreme as those seen in mania. We also have cyclothymic disorder, a subclass where individuals experience numerous periods with hypomanic symptoms that do not meet criteria for a full hypomanic episode, as well as mild depressive symptoms that do not meet criteria for a major depressive episode. These symptoms must occur for 2 or more years, interrupted by normal moods lasting no more than 2 months at a time. These sources identify biological, cognitive, behavioral, and sociocultural causes for mood disorders. Research shows a strong genetic link. If one identical twin is diagnosed with depression, there is a 46% chance the other twin will be as well, compared to 20% in fraternal twins. For bipolar disorders, identical twin concordance rates can be as high as 72%. Scientists also speculate that depression may be tied to the 5-HTT gene on chromosome 17, which regulates serotonin activity. Biochemical factors also play a role. Depressive disorders have been linked to low activity levels of norepinephrine and serotonin. For manic episodes, it is believed that low levels of serotonin and high levels of norepinephrine may be involved. Several brain structures are implicated in depression, including drastic changes in blood flow in the prefrontal cortex, a smaller hippocampus, and heightened activity in the amygdala. For bipolar disorder, the basal ganglia and cerebellum appear smaller. The cognitive model, often linked to depressive disorders, focuses on negative thoughts and perceptions. Learned helplessness, coined by Martin Seligman, suggests that individuals learn they are unable to control or avoid negative outcomes, leading them to feel helpless even when escape is possible. Research connects this to a negative attributional style, where individuals interpret bad events as being their fault, always happening to them, and happening everywhere. Aaron Beck's cognitive theory identifies negative thinking as a precursor to depression. Key concepts include maladaptive attitudes, the cognitive triad, and errors in thinking such as catastrophizing or overgeneralization. The sociocultural theory emphasizes the role of family and social environment. The family social perspective suggests depression is related to the unavailability of social support. For instance, separated and divorced individuals are 3 times more likely to experience depressive symptoms than married individuals. Regarding gender differences, women are twice as likely to experience an episode of depression as men. Several theories attempt to explain this imbalance. The artifact theory suggests clinicians are more sensitive to diagnosing women. The hormone theory suggests variations in hormone levels trigger depression in women. The life stress theory suggests women are more likely to experience chronic stressors such as poverty and discrimination. The gender roles theory suggests that traditional gender roles, where women are encouraged toward interdependent functioning, influence depression rates. Finally, the rumination theory suggests women are more likely than men to ruminate on their depressive symptoms, increasing vulnerability. Treatment for depressive disorders often involves psychopharmacological interventions, psychotherapy, or a combined approach. While medications may reduce symptoms more rapidly, psychotherapy or a combined approach is often more effective for long-term relief. Selective serotonin reuptake inhibitors are common first-line medications. They work by blocking the reuptake of norepinephrine and serotonin, making more neurotransmitters available. Side effects are relatively mild and can include nausea, insomnia, and reduced sex drive. Tricyclic antidepressants also block the reuptake of serotonin and norepinephrine. While effective, they have been largely replaced by SSRIs due to reduced side effects. MAOIs, or monoamine oxidase inhibitors, prevent monoamine oxidase from removing excess norepinephrine, serotonin, and dopamine, thus increasing these brain chemicals. They are not typically first line due to safety concerns regarding hypertensive crises, and strict diet restrictions. Psychotherapy approaches include cognitive behavioral therapy, behavioral activation, and interpersonal therapy. CBT is based on the idea that cognitions, behaviors, and emotions are interconnected. CBT involves increasing pleasurable activities, challenging automatic negative thoughts, identifying negative thoughts and how they maintain symptoms, and changing those thoughts to more positive ones. Behavioral activation aims to increase the frequency of behaviors so individuals receive more positive rewards and reinforcement in their lives. Interpersonal therapy focuses on managing current interpersonal issues such as complicated bereavement, role disputes, or role transitions to alleviate depressive symptoms. For bipolar disorders, psychotherapy alone is generally not sufficient. The first-line treatment option is mood stabilizers such as lithium or Depakote. Antidepressants alone are often avoided early in treatment because they can trigger manic or hypomanic episodes. Psychological interventions are generally paired with medication and primarily aim at medication adherence. Many bipolar patients stop taking their mood stabilizers when they feel better, desiring the euphoric highs of manic episodes. Social skills, training, and problem-solving skills are also helpful. That wraps up our detailed look at mood disorders, understanding the clinical distinctions, like the difference between MDD and PDD, or manic and hypomanic episodes, along with the biological and cognitive foundations, is crucial for grasping why certain treatments, like mood stabilizers for bipolar disorder or CBT for depression, are so effective. If you found this video helpful, please like and subscribe for more deep dives into psychology. Let me know in the comments below which part of the etiology section you found most surprising. Thanks for watching, and I will see you in the next video.